Welcome to the Chronic Pain Network Update and Future Plans webinar. We're glad you're here. My name is Angie Hunt. I'm a project manager with the Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to the CIRPD. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and also to ask any questions you have related to the presentation. We will collect questions submitted through the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all of these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Norm Buckley. Dr. Norman Buckley has been a faculty member of McMaster University since 1988. He has served 3 terms as professor and chair of the Department of Anesthesia, Michael G. DeGroote School of Medicine. Having held hospital administrative positions as operating room director, chief of anesthesia, and deputy chief, Dr. Buckley's particular interests are pain, both acute and chronic. His clinical work is focused on chronic pain management at the Michael G. DeGroote Pain Clinic, McMaster University Medical Center. In 2010, Dr. Buckley established and is the director of the Michael G. DeGroote National Pain Center. He is Scientific Director of the Michael G. DeGroote Institute for Pain Research and Care. In addition, Dr. Buckley is the nominated Principal Applicant and Scientific Director of the SPOR-funded Chronic Pain Network. With $25 million in funding, the focus of the network is improved health outcomes for Canadians living with chronic pain. Now I'll go ahead and hand it over to Dr. Norman Buckley.
Great. Thank you very much, Angie, for the kind introduction and for inviting me to speak here. Just before we get into the meat of the talk, just showing off my one of my hobbies here. You can just barely see me in the back row underneath the second A of American. Several months ago, the band that I play in, the Weston Silver Band, went to Fort Wayne, Indiana, where our contribution to making America great was to bring home the first section championship to Canada. So there is a life outside of pain management, in case anyone was curious. So the topic for today is the Strategy for Patient-Oriented Research, or SPOR, funded chronic pain network. This is one of 5 chronic disease networks that was funded under the CIHR's SPOR strategy. So their SPOR strategy was first announced in 2009. The intent from the CIHR standpoint was to enhance their research through the effective integration of patients, or what's referred to as patient engagement, into the processes of research, including helping to set patient research, or helping to set research priorities, also in the conduct of research and in the dissemination of research productivity. A huge stride forward for chronic pain was when the CIHR accepted that chronic pain did function in many ways as a chronic disease entity, and therefore was eligible under the Chronic Disease Network initiative that was announced in 2015. So we were able to go through the process of submitting an application, and in 2016, as you'll be aware, we received funding, and finally in 2017 we've actually got through all of the various contractual arrangements amongst our partners across the country to begin flowing money out into the conduct of the network. This is just a photo from the official announcement in March 2016. You'll see it was a big deal for the CIHR. Lambo Day was there. It was announced by the Federal Minister of Health. She was Obviously, from my standpoint, she was announcing the chronic pain network, and it did in fact occupy a disproportionate amount of her emphasis. As a family physician, she spoke of her interest in the problems of chronic pain, but she was announcing all 5 chronic disease networks, which include a pediatric network, a renal function network, a diabetes network, and a GI function network. And there are actually some interesting potential collaborations amongst these. The group is really quite an extensive group. If you're at all familiar with chronic pain research in Canada, this is a who's who of chronic pain research. I'm the nominated principal investigator, which recognized the key role that we were able to play in putting together the application, but this really was a national collaboration. Al Finley, who's a pediatric anesthesiologist and pain researcher at Isaac Walton Killam Children's Hospital, affiliated with Dalhousie University. Alfonso Iorio, who's a hematologist, but who leads the Health Information Research Unit here at McMaster and is leader for our KT strategy. Cyril Schneider from Laval University, Bonnie Stevens at Hospital for Sick Children, Margot Latimer, also at Dalhousie. She's a researcher in Aboriginal health and particularly Aboriginal children's health. Pierre Frechette had a key role within the Quebec Ministry of Health with the chronic pain portfolio, and Quebec is significantly advanced by comparison with the rest of the country in terms of developing a provincial strategy around pain. And so Pierre was kind enough to affiliate with the application. Manon Chouanière is at University of Montreal. Karen Davis, imaging researcher at the University of Toronto, Toronto Western Hospital site. Ian Gilron, an anesthesiologist at Queen's University and well known for his groundbreaking research in chronic pain treatment. Joy McDermott is a PhD epidemiologist whose clinical background is in rehabilitation science, physical therapy, occupational therapy. She's a professor at McMaster and now at Western University. One of our, actually her chair is in sex and gender, and she brings that perspective. Jennifer Stinson, another PhD nurse researcher at Sick Kids. Patricia Poulin, who is a psychologist affiliated with the Ottawa Hospital Pain Clinic, and whose contribution here has been around the process of patient engagement and developing research priorities. Maria Hudspeth in British Columbia, CEO of Pain BC, which is an advocacy group which has brought together clinicians, patients, policymakers, and is helping to formulate and work with the BC government to develop a provincial strategy around pain research and care. And Luda Diachenko at McGill University, who is a basic scientist, a geneticist, and made major contributions to a genetics trial in chronic pain in the United States called the OPERA trial, looking at facial pain, and she's now leading a significant project within our application. So this really is a national collaboration, and it's covered patients, researchers, healthcare professionals, et cetera, et cetera. The key reasons for doing this, first of all, chronic pain is to some extent flying under the radar, but it is probably one of the most common conditions, may affect as many as 20%, actually in some age groups more like 30%, anywhere from 15 to 30% of Canadians will be affected by chronic pain to a significant degree. The cost in terms of healthcare and lost productivity is more than cancer and heart disease combined. One of the complexities is that the traditional medical model of thinking of making a diagnosis, administering a treatment through medication or surgery, and then returning to normal function is not a model which is effective for chronic pain. And so getting that message out and into not only healthcare professionals, but systems of care is a crucial part of the problem. Healthcare professionals are not adequately trained. It is commented on that in a 3 or 4 year medical school curriculum, for example, fewer than 20 hours in total are devoted to treatment, to understanding the mechanisms and treatment of pain. That is changing over time. That information is about 6 or 7 years old, but it is still true to a significant extent, and it means that existing practitioners are also not adequately trained. And then the other issue is the involvement of patients. Patients have obviously a particular interest in this, but in some ways even more so than they may in other disease forms, because at the present time there are no objective measures of pain, and so it's patient report and interactions with patients that go crucially into creating the appropriate assessment and treatment of pain. And so between that and the need for effective lobbying to direct appropriate resources, the opportunity to integrate patients into the whole process of changing the way we manage pain is really a fabulous opportunity. A little bit of history for people that may or may not be aware of. This is a very successful collaboration. It's a bit of a dark horse in a way. I don't think anyone really expected that we would be successful, given that there were 20 applicants in the end for the 5 potential networks, and prior to that there were I think nearly 40 applications at the letter of intent level. But it builds on a history. So there, some years back, Mary Lynch at Dalhousie led a Canadian pain trials network. Dwight Moulin at Western University created something called the Neuropathic Pain Database, which made some significant contributions to our clinical understanding of treating patients with neuropathic pain. Jim Henry, who's my predecessor here as the director of the DeGroote Institute for Pain Research, was the principal investigator on a knowledge translation grant. One of the things that was built into that grant was a process of several deliberative dialogues led by John Lavis, who does healthcare policy research here at McMaster. Those dialogues significantly informed our structure and strategy around creating this application. Barry Cecil, who's a well-known professor emeritus at University of Toronto in the dentistry faculty, but also a leader in chronic pain and pain research and education in the country for a number of years, past president of the Canadian Pain Society, and also Christine Chambers, a pediatric psychologist who does research in pediatric pain. They have previously made network applications, which ultimately were not successful, but started to galvanize the community in how to come together to create a successful collaboration. In 2012, Mary Lynch and John Clark at Dalhousie University and University of Calgary, respectively, had presented a national pain strategy to the government on Parliament Hill. It did not get a great deal of uptake at the time, but once again it further raised the public face of the problem of pain and chronic pain in particular. The Canadian Centre on Substance Abuse several years ago now announced its first do no harm strategy in addressing the problem of prescription drug misuse, particularly what's become termed as the opioid crisis. Key elements in their strategy include specifically enhancing undergraduate healthcare professional, postgraduate healthcare professional, and continuing education for healthcare professionals in pain assessment and treatment, and also supporting further research into understanding the condition of pain. In terms of training healthcare researchers, Bonnie Stevens at the University of Toronto Sick Kids Hospital and Pat McGrath at Dalhousie are leaders in the field of pediatric pain research, and they were able to obtain strategic training initiatives in health research grants to support what was called Pain in Children's Health, the STIR programs, which led to a tremendous growth in training researchers in pediatric pain. And we're using that same strategy to inform our strategy around the enhancement of pain research across the board, pediatrics, adults, seniors, for our research strategy. As I said, the province of Quebec is significantly advanced in terms of its development of a provincial strategy around pain, both research and clinical care delivery. And the QPRN, the Quebec Pain Research Network, was one of our key collaborators, and one of the projects we've built into this has been an expansion of the Quebec Pain Registry across the country under the leadership of Manon Chouanière, but with collaboration from Mark Ware and Nicolas Baudet, who leads the Quebec Pain Research Strategy. And Pain BC, as I mentioned earlier, Maria Hudspeth, one of our principal applicants. This is again an example of a well-developed provincial advocacy group, which is leading nationally in terms of its formation of a well-oiled provincial group to bring our strategies forward, and so that seemed an obvious collaboration to build upon. It started with Kathy Smythe, an anesthesiologist who at the time was a director of the University of Ottawa Hospital Pain Clinic. She began the registration process using connections from a group called APDOC, the Academic Pain Directors of Canada. This is an ad hoc committee at the Canadian Pain Society, which originally started mostly so that we could cry on each other's shoulders about how poorly we were dealt with. They were the clinical and academic leaders of university-affiliated pain clinics across the country. But over time, the group has developed as educational advances have occurred. We've developed many more positive things to talk about, such as the Royal College Residency in Pain Medicine and enhancing research in pain. And so this group was strongly behind the development of the application, and in fact many of the participants in the application are drawn from the APDOC group. We registered for the competition in the fall of 2014, submitted a letter of intent that was developed through the fall of 14 and early 2015. The letter of intent was accepted in March 2015. We proceeded with the funding from the letter of intent to hire a project coordinator, who was Don Richards, and then spent the ensuing 5 or 6 months developing the full application, which was submitted in October 2015. Dale Tomlinson, who is our administrator here at the DeGroote Institute, also worked with Don, as did a significant number of other people, to both create, write, and fulfill all of the administrative requirements, including about 1,000 pages of appendices, including common CVs, letters of support, etc., which went into creating the application. We really have a national collaboration. You'll see that we have network partners, and we'll list those a little more fully in a moment, but also a significant number of patient and caregiver representatives who again are spread across the country, hitting nearly all the provinces, and we're working on enhancing that. In terms of patient and caregiver involvement, you'll see that there was a priority setting exercise, in fact, in pretty much parallel with the development of the application itself. Patricia Poulin at the University of Ottawa and Jen Stinson at Sick Kids, University of Toronto, had a collaboration grant from the CIHR, and that, along with some funding from University of Ottawa and the DeGroote Institute here, was used to create a list of research priorities. This involved quite an extensive series of events, focus groups, contacting patient advocacy groups for pain conditions across the country, soliciting input from a number of groups. One of the interesting outgrowths of that was the recognition of the unique contribution of Indigenous and Aboriginal communities, and so that has led to us having a specific Indigenous Health Research Advisory Committee within our structure. Each committee that we have has representation from patients, including a patient as a co-chair. Our goal is to take the existing research projects and integrate patients into the operation of these projects, which we think will provide several opportunities. One will be to have an impact on the projects themselves, but also for us to learn something about what are the optimal processes. The business of patient engagement and research, although there is a history of research in the field, is still at its early days in terms of how it actually plays out in the development of research priorities, the selection of priorities, and then the actual conduct of research. And so we're looking, particularly in the pain field, to both improve our performance there, but also come to understand the performance more. And so we've developed training programs. Some of them we've developed internally, and some of them have been adopted from groups like the University of Montreal Research Group in Patient Engagement under Antoine Boivin's leadership, also with the what are called provincial SPORE support units, which exist across the country, and several of them offer patient engagement training for both patients and researchers as part of their contributions. So there's really quite an interesting integration of patients and caregivers into the process and into the network. This is our organizational chart. A lot of the work happens at the advisory committees that you see on the bottom level. So the Patient Engagement Committee, the Training and Mentoring Committee, Patient-Oriented Research, Knowledge Translation, and the Indigenous Health Research Advisory Committees all have fairly regular meetings, currently about once a month, although we anticipate those will spread out a little bit once the strategies are underway. All of these committees report to the Executive Committee, which is comprised of the chairs of the committees, along with the members of the National Coordinating Center and the principal investigator, myself. And then the steering committee is comprised of all of the principal applicants plus representatives of the key industry partners, the sponsoring institution, McMaster University, patient partners, and the Alberta Children's Health Research Institute. So the steering committee meets several times a year. The executive currently meets about every 6 weeks. And then we have these other groups, the Registry Working Group, which is led by Manon Chouanière, which is working to establish the National Registry of Patients with Chronic Pain, a Clinical Research Network, which is a network of university-affiliated pain clinics who will participate in research. And we're interacting and trying to establish the principles of interaction with the provincial SPORE support units. So just to go over the committee descriptions themselves, as I said, the steering committee has the overall oversight of the strategic plan. It is obviously strongly represented by leaders within the network, the principal investigators, as well as patient representatives, the host university, and supporters of the network. The executive committee is basically the National Coordinating Center plus patient representatives and the leads from each committee. The Coordinating Center is our key, really where the work happens. And yes, I know they're listening, but it really is where the work happens. It's the nominated principal investigator, myself, but Kim Buckley, who's our managing director, Megan Groves, our communications coordinator, and Donna Marfisi, the administrative assistant. The Patient Engagement Committee is a group comprised of patients led by Maria Hudspeth, and this group has had several roles. First of all, Maria and her team have solicited patients and caregivers to be involved in the network, and particularly to be the volunteers, well, to be identified as the individuals who will both assist in the selection and delivery of training and patient engagement, to provide the patient level input into the overall network direction and activities, but also on an individual basis. Each research project, and you'll see the list of them in a few moments, will have a specific patient individual who assigned to work with the project initiator and research leader. And the ongoing work there will be to both work out the most effective patient engagement, but also provide us some feedback about what things work and what things don't. The Patient-Oriented Research Committee at this point is providing oversight of the research initiative. So in putting together the grant, we had identified 27 projects, which you'll see listed in a moment. The Patient-Oriented Research Committee will be responsible for reviewing these projects to make sure that they adhere to their timelines in terms of successful productivity. We'll be making the difficult decisions, if necessary, around stopping projects that may fall off track, and also going through the challenging process of looking at subsequent applications in years 3 through 5 for new projects that we want to entertain, and helping to advise the executive on how to direct overall resources. Obviously, there's a lot of liaison between the patient-oriented research and patient engagement, knowledge translation committees, and ultimately the clinical research network. The training and mentoring committee, and that patient-oriented research committee is led by Cyril Schneider. The training and mentoring committee is led by Bonnie Stevens. This group is either creating new opportunities or creating linkages between trainees and existing opportunities to ensure that we make the best advantage of the resources we have and encourage the most successful development of new researchers. One of the other things that this committee does is to take an interdisciplinary undergraduate health professional pain education program, which was developed at the University of Toronto, and our goal is to have this curriculum made available to healthcare professionals across the country to avoid the need for creation of new curricula, but also to allow individual organizations, universities in particular, to adapt the curriculum in such a way that it becomes effective for improving education in pain, in an understanding of pain mechanisms, diagnosis, and treatment. The Knowledge Translation Committee is obviously one of the key goals of all CIHR-supported research is to ensure excellent knowledge translation. So Alfonso Iorio at the Health Information Research Unit here at McMaster is leading the knowledge translation strategy using some existing tools such as there's a product here called McMaster Plus, which is a literature surveillance product which has been retooled a few years ago called McMaster Pain Plus, which has now been relabeled CPN Plus, the Chronic Pain Network. And it's a literature surveillance and notification and updating project that with the additional funding from the Chronic Pain Network has more than doubled the number of journals that it has under surveillance. And what they do is to identify high quality, methodologically sound articles and then circulate them to a group of raters within the pain community who identify things of particular interest and importance. And those articles are then made available to subscribers by what they call a push-out process. So rather than simply being a knowledge repository, which they also are, and you can come in and search their existing databases for articles, they are also they have a push-out product so that usually a couple of times a week, I will receive several email notifications of new articles in the pain field that are considered methodologically sound and also interesting, and it helps to maintain awareness of what's going on. The Indigenous Health Research Research Committee is led by Margot Latimer and her colleague John Siliboy at Dalhousie University. They've already created a compendium of resources which can be used to advise healthcare researchers in the appropriate processes for engaging in healthcare research with Aboriginal communities. For those of you that might be attending the Canadian Pain Society meeting this year in Halifax in May, there will be a poster presented there with this information. But the committee it exists to help ensure that we both are respectful and interact effectively with Aboriginal Aboriginal communities, but also make the best advantage of the resources that we have to ensure that pain-related research is carried out in recognition of specific factors to do with pain treatment in Aboriginal communities. One of the interesting observations is that many First Nations languages, for example, in Canada, do not have a word that identifies pain in the same way that the English word does. So there are words for hurt, but the concepts of pain, and particularly chronic pain, are much more challenging to convey. And so some of the work that Margot Latimer is doing is into things like what are the appropriate question sets to ask Aboriginal children if you're interested in finding out about pain. The registry working group is trying to create a national approach to the registry of patients with chronic pain to make them available for large-scale population-based health research in chronic pain. This will include interacting with the genetics research project to create biobank material. The Clinical Research Network is a pretty neat thing that we have created, which is one of those mixed blessing things. It's either going to work really well or it could be a bit of a boondoggle. We're hoping for the former, but we have 12 university-affiliated pain clinics across the country, and the history of these has often been that they're very busy clinically but don't have a lot of local resources available to support research. So what we've done is, in collaboration with each of these 12 organizations, agreed that we will co-fund a research coordinator at each site. So each site puts up half of the funding, the network has put up half the funding, with the expectation that there will be a full-time research coordinator available at each of these 12 sites to participate in network-generated research, also to support locally generated projects which may then become multi-center trials across the country. This is also a group we're looking to start populating the national registry or to solicit patients to participate in the biobanking and things like that. I mentioned the SPORE provincial support units. Support is actually an acronym which has to do with providing resources directed towards patient-oriented research at the provincial level. They're co-funded by the CIHR and the provinces. They were in existence for several years before the national chronic disease networks came into play. They have been interacting with the two pre-existing national networks, the Primary Care Network and the National Network for Adolescent and Child and Adolescent Mental Health. But because these are often based around pre-existing busy research units, the challenge has been figuring out what the appropriate relationship is between the new national chronic disease networks and the existing SPORE provincial support units. So there are a lot of ongoing discussions about this, and we've had several national meetings now involving these SPORE support units and the national networks. And I think we're getting closer to a viable solution. Certainly there's a lot of ongoing discussion going on about where our goals may be congruent, and that should lead to increased productivity. Just a listing of the 12 university-affiliated pain clinics that make up the Clinical Research Network and their local principal investigators. You'll see that we go from literally from coast to coast and every province in between, including McGill in Quebec, several institutes or universities in Toronto, in Ontario, University of Manitoba, Saskatchewan, Calgary, Alberta, and UBC. So we're very pleased to have that breadth of support. Some of the key network projects I've already mentioned. The Pain Plus CPN is this HIRU-led database of vetted articles. The genetic analysis of patients, beginning with the Quebec Pain Registry, will create a large-scale biobank. The National Pain Registry, again, will add to the clinical registry. And there's 27 specific projects identified in the fields of basic science, behavioral science, population surveys, and clinical trials. I'll just quickly go through some of these, but it includes several projects led by Thomas Hadjistavropoulos on pain in seniors, a music research project which is interesting because it studies not only clinical use of music as a pain intervention, but also looking at a bit of the basic science of is there a physical mechanism in addition to the say more metaphysical intervention that happens with the use of music. Cyril Schneider at Laval leading trials of neuromodulation, research into groin pain. Jen Stinson has done a number of investigations using smartphone applications, both for research but also for clinical interventions. One of her former grad students, Karine Tupin-Avril, is using development of decision support aids, and this is a key thing for providing information for clinicians in how to interact effectively. Their focus is on juvenile idiopathic arthritis, but the concepts extend across quite a wide range of things. As I mentioned earlier, Ian Gilron and several colleagues are looking at combination analgesic development as a clinical trial. Dave Walton at the Western University, which was formerly University of Western Ontario, before they became Prince-like in their new naming. And they have a really interesting long-term project which is looking at biological correlates along with mental health and environment, and creating a data bank, including biobanking material that can help to identify predictors of the development of chronic pain. Also, more specifically around upper extremity fractures or elective arthroplasty. Gurmeet Singh, who's a basic scientist here at Mac, cancer researcher with a significant interest in bone pain, looking at targeted therapies. Steve Prescott and Mike Salter's group at Sick Kids looking at patient-derived neurons. This is an enhancement of stem cell type research, but also linking with cancer pain patients. Karen Davis and Cyril Schneider. Interestingly enough, some of Karen Davis's imaging work using imaging to identify the brain site correlates of pain experience has begun to drift also towards into the medical legal field around using some of these imaging strategies to measure whether or not patients have, quote, real, unquote, pain. So one of Karen's major concerns is that any work of that sort that will take basic science research and try to extend its application into fields that were not originally intended be informed by really excellent oversight of the neuroethics, and so that's part of her collaborative work with Cyril Schneider. Luda Diatchenko, as I mentioned, is developing the biobank of samples from chronic pain patients. More discussion of the music effects of music on chronic pain. Circadian control of chronic pain, looking at circadian rhythm, Ian Gilron and Nader Gassamlu at Queen's. But that work is also extending across the country with other collaborators as we get the network underway and begin to really find the depth of interest and availability of resources. And we're really hopeful that this network is going to lead to greater efficiency in generating new knowledge from existing information which has been gleaned. Strategic approaches to personalized diagnosis, the role of parent mental health in pediatric pain, relationships between generalized anxiety disorder across the country, chronic pain in the emergency room, surveillance studies of complex regional pain syndrome, things like the Pediatric Pain Implementation Toolkit led by Bonnie Stevens. This is a practical bedside knowledge translation initiative. Bonnie's been very successful with this project, And in fact, one of her current applications has her spending a fair bit of time in Ghana in Africa, applying these interventions at the bedside, even in areas with limited technological support and expertise for their healthcare, are able to achieve significant pain treatment improvements by applying these interventions. Ken Craig has some fascinating facial recognition research that he's been engaged in for many years around pediatric pain, and he's continuing to apply this. He has grants through the National Institutes of Health in the United States, and is contributing to our research endeavor by bringing some of that work into a facial recognition analysis and the applications of that in clinical care here. I think I mentioned Margot Latimer's Aboriginal Children's Hurt and Healing Initiative already. When I talked about the fact that we were approved in 2016 and first began to flow the funding in 2017, this is part of the reason for that. All of these institutions are supporters of the network. Many of them are financial supporters in terms of either matching funds being allocated towards research within the auspices of the network or in-kind funding. The $25 million referred to in the introduction represents $12.5 million of new funding from CIHR, along with $12.5 million that we had to bring to the table. So you can see we had to bring together a large number of partners, and since each of those partners has to be a signatory to the overarching partners agreement in order for the organization to proceed, this is where we've spent about 6 or 7 of the last 12 months in achieving all of the signatures necessary here. So that is, it also I think is a remarkable statement about the breadth of interest that exists in Canada for this topic of pain research. So that's the end of the formal presentation. I'm more than happy to accept questions, and I think that I've managed uncharacteristically to leave enough time that we can have a reasonable discussion. So Angie, I'm going to turn it back to you if that's okay.
Thanks, Norm. So we had a few questions come in. You might have already answered this, but you had one of the questions was, what are some initiatives you see coming down the pike? Or are there any other research opportunities?
Well, I'll tell you something interesting about this. I did summarize at the end. So when you create an application like this, the formal funding is defined as a 5-year network funding, and the official instructions we had was that the funding was not to be considered renewable at the end of 5 years. Having said that, one of the things that we did develop, and I haven't really emphasized much here, was the beginnings of a sustainability strategy, which fits into a national strategy around pain, and that's going on in the background. But the other, one of the other interesting things is, apart from the sustainability part, is that we had to identify projects that were named in the application so that the reviewers could see that we had the knowledge, ability, and engagement to actually carry out research. It's one thing to say, oh yes, we'll get together and we'll be fabulous and we'll do a really good job. But we were actually, we placed concrete projects, many of which have already achieved, even prior to submitting the application, had already achieved ethics board approval in various universities, to say that these are projects which we can in fact carry out, and if funded, we will carry them out. And so a number of the 27 projects that I listed there, all of those are in the process now of receiving their initial first-year startup funding. So those things are both our first items of business, but as they start up, they're also generating new interest. We've had, I think I mentioned Nader Gassamlu's, one of his projects on, it's one of those complicated, proteomics, I'm sorry. on proteomics, and his initial proposal was to solicit from patients the necessary biological samples. That was going to be about a 12 to 18 month project to identify the appropriate patients, get phenotypic information, and collect the biological samples from patients across the country. Since the network was awarded and we began to liaise with people, including research, for example, some of our discussions during the development of the network included meetings with people like the Rick Hansen Research Institute. Now, they were affiliated with another application that was not successful, but they have a keen interest in pain. Similarly, the Arthritis Institute, which did lend some both in-kind and financial support to our application, has a keen interest in pain. And through his contacts in other groups, Nader Gassemlou has actually already identified the patient population and the existing biobanks, because some of his colleagues across the country had already created banks of materials. So in fact, we're able to get a bit of a jump start on some of these projects. So it's collaborations like that that are coming into play. We've been approached by the Departments of Veterans Affairs and the Canadian Forces Health Research and Health Delivery programs, and they're interested in pain. Pain is a significant issue for both for retirees and also active members of the forces. And the Department of Veterans Affairs obviously has responsibility for health care for retirees from the forces. And so they're very interested in how they may be able to make collaborations which will enhance their efforts, and perhaps their resources can enhance our efforts. We've had approaches from other organizations, some organizations, for example, in Toronto. At the time we created the application, the Toronto Academic Pain Medicine Institute was not in existence. There were discussions about it. Over the 2 years between us initiating the application and being successfully funded, they actually came to fruition, and we've met with them about how their processes may be either collaborative with us, or how we can at least avoid recreating wheels depending on how things go forward. We're looking for other collaborators now that the network actually exists. We had surprisingly, at least surprisingly to us, but when I began to understand the field, maybe not so surprisingly, little interest from the pharmaceutical industry, which has traditionally been a big contributor of matching funds to this sort of application. However, there were not many new products in the pipeline, which is partly how they make their financial strategic decisions. We did get support from Purdue and Eli Lilly. We also got support from a California biotech firm called Prove Biosciences, who are leaders in the field of genetic screening and the application of that in healthcare. So we're now starting to revisit some of pharma, because now that the network exists and we have the clinical research network in play, for example, we see some potential for using the clinical research network to support new drug trials and perhaps generate revenue for the ongoing support of the network, as well as leading to a sort of more rapid evaluation of products. So, some of these things are we're just beginning to realize, as we actually get things on the ground, what the potential benefit may be in ways that we haven't really seen. That probably is a bit of a lengthy answer to what should have been a simple question, but there you go.
Very thorough. Another question that came in is, the first do no harm opioid crisis seems to have caused a setback for prescribing opioid medications for people in pain. It seems people in pain are coming in second to addicts, and the new policies causing more suffering for us. Are any of your committees providing input into the policies or research?
So actually, that's a great question. If you read the first do no harm strategy in its entirety, it has a very big emphasis on pain. It's recognized that a lot of the opioid prescribing issues that arose because there were very few effective tools to treat pain apart from opioids. And even now we've come to recognize some of the limitations of the use of opioids and perhaps some of the risks in a way we didn't realize 20 years ago when we were beginning to prescribe more widely. But also, so the business of pain as an important driver in this crisis is very well recognized. The strategy makes great emphasis on the need to support research into pain and also to enhance the availability of care. And much of the care that is seen as both, I guess, first-line care, but also necessary and important care in treating chronic pain are things like physical therapies and psychological counseling, which in many provinces, in fact most provinces, are not readily available under the provincial healthcare systems. So we have already seen, for example, in Ontario, at least at the university clinics, that there's been a significant rollout of funding to support non-medical care in university-affiliated pain clinics. That's about $17 million added to annual base budgets of the university-affiliated pain clinics in Ontario. Quebec similarly has strategies, but all of these things are being played out across the country. There's good federal support for the concept, and the challenge is seeing that federal support for enhancing this availability of care extends into the provinces and their own responses. There's no question that the identification of the risks of opioid prescribing, and not just addicts, but accidental and intentional overdose deaths, and it's been also confused and conflated by the real surge of extremely potent illicit drugs into the market, which unfortunately use the same names as the illicit drugs. So fentanyl, for example, many of the deaths that are occurring now are occurring from illicit products, but it's difficult to separate that out of news articles. So we see a steadily rising death toll from opioids, and many of the deaths are not from appropriate prescribing. We also see that they are prescribed in some cases inappropriate conditions or at inappropriate doses. But I agree that the other challenge is there are a number of patients who have benefited and in many cases are able to function because of their access to opioids. And there's a huge challenge in trying to identify those patients and see that they retain access to the care which has been beneficial for them. In terms of advising policy, not so much part of this research network, but the group that carried out the revision of the Canadian opioid guideline, which was circulated for public input about a month ago and will be released in early May. That guideline makes very strong reference both to the potential dangers of initiating opioid use, and so the caution that's needed to be used in opioid naive patients, but there's also a very strong emphasis on the need to not withdraw care from patients who are benefiting, particularly with objective measures like return to work function or ability to manage their activities of daily living. And when you have that kind of information in a patient who's been stable on opioids, even if their dosing exceeds the currently suggested upper limits, that we should not be denying those patients their continuing care. And that message is I think it's an important one. Certainly as part of the network activities include developing briefing materials for healthcare policy. I mentioned John Lavis as part of the support for the network strategy, but he's also agreed to carry out further deliberative dialogues in the middle and latter portion of the network's 5-year lifespan to make that kind of information available for healthcare policymakers. So again, it's a complicated situation. The challenge is preventing harm from inappropriate use while at the same time preventing harm from withdrawing care. And we've seen examples of all of those things, and it's a real challenge to maintain a balance.
Thank you.
Okay. And another question is, you mentioned what production of healthcare research for healthcare professionals. Are those resources only available for healthcare professionals, or can anyone read them? And if so, where can we find them?
Actually, that's one of the really neat things about about HIRU, the Health Information Research Unit, who are leading that Pain Plus CPN project, is that they have first of all, anyone can sign up for the service. You don't have to be a healthcare professional. If you go to the website of the Health Information Research Unit at McMaster University, or Google Pain Plus CPN, you should be able to tap into the network. There are versions available both for the general public and for healthcare professionals that vary in the complexity of the information. One of the underlying projects that the network has in collaboration with the KT Advisory Committee is making time available, often from healthcare research trainees, to create plain language summaries of the articles or summaries of articles that will be identified and distributed by the Pain Plus CPN program. So yes, there is information available for the general public, and it is accessible through accessing the Pain Plus CPN. And I'm not sure because some of this stuff is in process, I'm not sure if that information is available right now as Pain Plus CPN, or if it might still be available under the Mac Pain Plus name, or through the Health Information Research Unit website, the HIRU, HIRU website at the McMaster Faculty of Health Sciences website.
Okay, we can include that in a link in our supplementary materials.
Great.
There are no more questions at this time. Do you have anything you'd like to add, Dr. Buckley?
I guess the things that I would add, we are in the process, the test site of our Chronic Pain Network website has been drafted, and we're currently sort of reviewing it, vetting it, revising it. It should be online by, hopefully, we're hoping sort of mid to late May. We're thinking it would be nice if we could announce the website at the Canadian Pain Society meeting. It just depends on how the process goes of setting it up here. In the meantime, if people had information that they wanted or questions, I guess the places to come currently are through McMaster University, the Michael G. DeGroot Institute for Pain Research and Care, the IPRC website, will have some of the links, or the National Pain Center website. The National Pain Center is where we house best practice guidelines for treatment of pain. That's where the existing Canadian opioid guideline is, and the revised guideline will appear. And that is, so it's a source for a number of things, but some of the information you're looking for may currently exist there before we link it across to the new CPN website once it gets underway. Okay?
Okay, we can also include that in our supplementary materials following the webinar.
Great.
Well, thank you very much for your presentation. Thank you for joining us.